particular event. Someone is asking for the link. So is this link for all? Can it be shared?
No, faculty link.
This is a faculty link, Dr. Parekh.
Yeah, but that WhatsApp group is also for faculty, or that's a different group?
No, you can just share the RX event group. They will automatically register and reach the delegate group. The RX event group, na?
Right.
Yeah.
I will share. You continue with this.
Okay.
Sure.
Okay.
Good to go, ma'am.
Good to go?
Sir, good evening. Najib bhai, good evening.
Yes, very, very good evening, Rakesh. Welcome. Amit, Manoj had not joined?
I will call him. I will ask him.
So Sangeeta could get only female members of. So at least from Diabetes India, you should have some male members also. You should not be gender biased.
I see a lot of male members on the screen.
So they all are from Diabetes India, not from the dental side. No? Sangeeta could not get
Oh, because there is nobody to get, no?
Sangeeta ma'am, you can start the program. It is already live. You can start the program.
Yes, please. So over to Sangeeta.
Okay, so shall we start now?
Yes.
Dr. Sangeeta, you are not audible to us. Please. Earlier, your audio was coming, but it is not coming now. No. Please remove your headphone. Earlier, it was coming fine. Disconnect the headphone from the computer. No. You are not audible. Dr. Sangeeta, you disconnect the audio from the computer. Use the earlier computer audio only. Your voice is not there, Dr. Sangeeta.
Still, we are not. Amit, you can start with till that.
Yes.
She joined again.
So, good evening, everyone, and a very warm welcome to all of you for this first webinar by the Diabetes India and Diabetes India Oral Health Interest Group. And we have a number of luminaries with us. And since Dr. Sangeeta is having some difficulty with the audio, so I will request Dr. Sumita, who is well versed with the flow of the program and everything, to conduct the session till the time Dr. Sangeeta joins. So, over to you, Dr. Sumita. Please go ahead. Right.
Yeah. Hello and a very good evening to all. First and foremost, I would like to thank each and everyone here for sparing their precious time. I, Dr. Sumita Bansal, co-chair DIOH, would like to welcome you all on behalf of DIOH Group to our first online scientific webinar, which will be a 2-day extravaganza. As you all are aware, the topic of discussion is oral disease and diabetes, the diabolic duo. There will be several informative scientific lectures and a panel discussion by eminent speakers from the specialties of periodontology and diabetology. Moreover, DIOH patient education pamphlet is also scheduled to be released. So I'm sure the discussion in today's webinar will be great and successful. Now we start the program with the introduction of our moderator so that she can commence the meeting. I feel quite elated to introduce our moderator, Professor Dr. Sangeeta Dheer, a big name in the world of periodontology. She did her master's in periodontology from College of Dental Sciences, Davangere, Karnataka, and clinical externship program in implantology from University of Birmingham, UK. She has been credentialed by International Congress of Oral Implantology as a fellow. She was the ex-core committee member of National Oral Health Program, Ministry of Health and Family Welfare, Government of India. She has served Indian Society of Periodontology in various capacities. She has been the ex-vice president, executive assistant of ISP. She was the ex-editor-in-chief for the Journal of International Clinical Dental Research Organization. She has been key opinion leader to the various oral pharmaceutical companies. She was the organizing secretary for the first National Symposium in India on Periodontitis and Diabetes, which was a collaborative event of RSSDI and ISP. Apart from this, she also has numerous scientific publications and has been keynote and guest speaker at several dental and medical conferences on national and international floras. So here I welcome one of the most dynamic personalities, Dr. Professor Sangeeta Dheer. Over to you, ma'am.
So Medha, I think Dr. Sangeeta is still facing difficulty. So till the time she joins, you can continue with the presentation.
Okay.
Dr. Dheer, can you stop sharing your screen? मैम आप Dr. Subedha, you can continue with the inauguration and you can invite our chief guest and whatever is the flow. So we are sorry for this technical glitch. I think Dr. Sangeeta is facing some difficulty. So she will join back very soon. But Dr. Sumedha, your audio is also not audible. You are not audible to us.
Just a second. I think
both the mobile and the laptops are on, connected to the Zoom, and then is a problem. I think one of them, it should be disconnected. The mobile should be disconnected, getting into the Zoom.
So let me conduct the program till then. Dr. Sangeeta is joining. So I will request the RX team to play the Ganesh Vandana or the Saraswati Vandana and the lamp light.
या
after invoking the goddess Saraswati. Now there is a small video which is prepared by the DIOH team. So I will request the RX team to play the video, please. So this was the video about the Diabetes India showing the activities. Now we have Dr. Bansi Kabu with us, who is the Secretary of Diabetes India and also the Chair-elect of IDF Southeast Asia. Sir, I will request you to give your opening remarks for this webinar series. Bansi sir, I will request you to give your remarks.
Yes, but am I audible?
Yeah, you are very much audible.
Okay. So first of all, thanks Sangeeta and Amit for this wonderful program which we have created. Already Diabetes India has been introduced to all of you. It is an organization with more than 25 years. Dr. Shaukat Sadikot was the founder, and late Shaukat Sadikot was also the past president of International Diabetic Federation. Currently, I'm the secretary for Diabetes India. Before 2 years, and with our joint secretary, Dr. Amit Gupta, he thought of that we should have a different interest group in Diabetes India, because diabetes is a subject where many people are interested in different subspecialty of diabetes. And thinking of a Diabetes India oral health, which is very, very important, and this interest group is created. We are very lucky to have with us Dr. Sangeeta, who is chairing this group, who is an eminent pediatrician, but not only that, she is very active in this interest group, and because of her only, we are having this program also, scientific program. So first of all, I congratulate Dr. Sangeeta for this wonderful program. As we are meeting digitally, but for these 2 days,
Bansi sir, your voice
is very clear that we want to create awareness amongst diabetologists or the physicians who are treating diabetes.
Sir, I think you should close your view. Your audio is very much. Bansi sir, I think he has left already. The network was poor there, Amit.
Now Dr. Sangeeta is back, I guess. Dr. Sangeeta, is your audio?
Yeah. Am I audible?
Yeah.
Yeah. So there's a brief technical technical glitch, which is just unprecedented. So allow me to share a quick PPT on the subject. 1 second. Okay, the next on the subject is a warm welcome, which is a little delayed. So let's just move on to the agenda. So we have a collage out here that is speaking many things out here. It talks about a correlation. It talks about poor dental health, diabetes, kidneys, a widespread prevalence, and the two-way street of the gum and the diabetic complications. So we are aware of certain things. We are possibly not aware of anything, and possibly we are still learning a process of learning a couple of things which are still under covers. It's an overview of the scientific facts before we really budge into the webinar proper. Oral health is a key indicator of general health, well-being, and quality of life. Oral diseases, in specific tooth decay, tooth loss, and periodontal disease affect about 3.5 billion people globally, which is almost accounting to half the world population. Oral diseases often manifest together with other non-communicable diseases, in specific diabetes, and which is why the oral diseases are prioritized as something which is closer to the NCD by the World Health Organization. Oral disease NCDs share the modified risk factors, and that is how it is important to have a multi-sectoral response in terms of existing effective solutions. Good oral health also has a positive impact on the NCD treatment, and that is why it is important to invest in more multidisciplinary researches and interprofessional collaborations across the healthcare teams. Having said that, GBD risk of 2021 recently published in Lancet, it talks about the Indian subcontinent to the projected estimate of 2050 as up to 6% of prevalence rate, and that's a huge number. Now we switch on to the periodontal global burden disease, something published in 2021. It talks about as 1.1 billion people suffering from the varied forms of periodontitis. In the 30-year longitudinal data that they had, the prevalence rate has been increasing by about 8.5% average. And coming to the Indian standards, the prevalence of periodontal diseases in diabetics is found to be about 87%. If we just dissect into two halves, gum disease is up to 28% and periodontitis up to 60%. Coming to what is the prevalence of periodontitis in clinically diagnosed cases of diabetes mellitus, overall prevalence in this huge volume of the population that was examined, it was about 68% in the diabetics, combined both type 1 and type 2, and about 36% in non-diabetic cases. Coming to the clinical parameters that we normally check, it has been found that the periodontitis severity score was higher amongst the diabetic groups. Now, this is the diabetic component. How about the pre-diabetic? I think that's actually a huge hazard which is facing the community. So a prominent study for 5 years data told us that the prevalence of moderate and severe periodontitis coincided to about 40 years of age amongst the pre-diabetic population. And in general, there was a high raised trend amongst all the section of periodontitis. So apart from the medical burden, it is important to understand, just like other NCDs, there's a huge economic and societal burden also, and it's time that we took gum disease seriously. So there was a clip that I found which possibly self-explains many things. So there is more to say about the disease from the oral origin, that is periodontal disease, and there's more to say as something spoonful of sugar. United, they are in a balance, and you leave them alone on their own, they are going to collapse the whole system. So with these few words, have we really arrived at a time when we are not talking about the solo management, or is it a time to integrate something known as a healthcare management? So this webinar is basically, aiming and trying to understand the day one, which is today, about the basic format, and tomorrow it's more of the clinical and the panel discussion, which is talking about the integrated healthcare. And that's an overview that we are going to be receiving on the 2 days of this webinar, and that is how we are going to initiate the next step. We have seen the AV of the DI. Now, Dr. Amit, may I have you as well, just as a small note from your side before we kickstart the remaining show?
Thank you, Dr. Sangeeta, for setting this up. I know there was some initial glitches, but I think now it is running smoothly. And I must congratulate all the team and all the dignitaries and the guest speakers and the chairpersons who are here, including our overseas guest, Dr. Purnima and Dr. Dominica, who was also here. So I would like to say this thing that this is a very, very important topic and often neglected. And the first step, rightly you say, was taken when two societies came together in 2019. And then there was a good practice guidelines which were published by the RSSDI regarding the oral care and diabetes. I think over the next 2 days, we are going to learn a lot, and we are going to explore the areas which are very much not being explored by the diabetologists. We are not looking into the oral cavity that much, and we are not taking care of the oral. And similarly, the dental fraternity is also facing a challenge that most of their patients, they have poor glycemic control, and that is also responsible for poor dental health as well as many other complications. So I think this is the point why we are together, and we want to work more, and we want to spread awareness, we want to develop science, and we want to see that how we can take it to the dental colleagues, diabetologist colleagues, physicians, so that we can improve overall dental care as well as the diabetes care through our streams. So with this note, I would like to thank Dr. Sangeeta and the entire team. And Dr. Sangeeta, we also have Dr. Dominica with us. So whenever you are comfortable, you can take her remarks also. And Dr. Bansi is just reaching the airport. So whenever you get the time, he will again join, and he will stay.
Sure. Thank you, Dr. Amit. Now we get on to the next agenda of the evening. Allow me to introduce the chief guest for today, Dr. Purnima Kumar. Can we have her bio sketch on the screen, please? So, Dr. Purnima Kumar, it's well was named in the Perio fraternity of India and abroad. So she has got a humongous contributions to her credit. So this slide would have been really trying to inch every corner. So I've just tried to assemble together so that we can have a fair amount of information about this lady. She has completed her basic dental studies from Annamalai University and went on to do her PhD in molecular biology from University of Ohio. She's a diplomat of the American Board of Periodontology and has got executive leadership from various academies. She's a principal investigator of oral microbiology ecology laboratory at the University of Michigan, which has been funded by NIH, NCI, and oral healthcare. She's an active researcher, clinician, teacher, and administrator, and has been a mentor and guide for many postdoc doctoral students. She's a chair of the Continuing Education Oversight Committee of AAP and has been the member of AAP's Task Force for Future Science. She serves on the board of directors of the Osteology Foundation. She's the chair of the Council of Scientific Affairs of American Dental Association and is the official spokesperson on e-cigarettes and vaping, on which she has hugely researched and published articles. She also serves on several task forces for women in science and women in STEM and volunteers for groups that empower women locally and nationally. Dr. Purnima ma'am, stage is yours, and we are waiting to hear you.
Thank you so much for that very kind introduction. It is such an honor and a privilege to be invited to be part of this wonderful group. I mean, it's deeply impressive that, India has a very dubious distinction of being the diabetes capital of the world. And for our physicians and scientists and dental colleagues and medical colleagues to come together to create a unified approach to healthcare management and, just care pathways of these patients is really very heartwarming to see. As Dr. Dheer said, I have done some work in this diabetes space also. And one of the most important findings for us was that what we consider a very simple treatment, which is deep cleaning and removing the bacteria from under the gums of people with what is known as gum disease or periodontitis, can have a very large impact on their glycemic control. So people are able to reduce their need for anti-hyperglycemic medication, and their hyperglycemia comes down. HbA1c levels are significantly reduced if we do something as simple as cleaning their teeth under their gum line. It's called deep cleaning, not just your regular cleaning, but cleaning their teeth under their gum line, as well as keeping them on continued maintenance. So every 3 months, they come back to us and we make sure that the bacterial load is low. So it is fantastic to see that this group will be talking about the biological mechanisms that underlie these pathways. I tell people, there's a thing there's a saying in the US here. It says, what happens in Vegas stays in Vegas. Vegas is Sin City, right? But I always tell people the mouth is not Vegas. What happens here does not stay here. And so really, if you think that the mouth is a part of the body and it is truly the gateway to the body, life begins in the mouth, and the mouth is the first organ that forms the interface between the environment and the human physiology. And therefore, the mouth is already set up. Evolutionarily, it has been set up to be a very stable, unchangeable environment. And it protects us by being unchangeable, by being, that kind of a stable environment. It protects us. It offers us a great deal of protection, because otherwise everything we eat or drink, or whether we kiss a partner or find a new, have a new baby, any of these life events can keep on changing the rest of our human body physiology. And so the mouth doesn't allow that to happen. It's truly a gatekeeper. And if we don't take care to protect events or the health of the mouth, then we put the rest of the body at risk. And truly, as as we begin this meeting here today, I'm grateful to hear this very important concept of healthcare cost. The cost associated with oral health care can significantly lower the cost of systemic health care. Would you rather simply just invest in cleaning your teeth and keeping your oral health intact versus staying lifelong on the treatment of other complications of hyperglycemia? That is something important. The other thing is, we are learning, as we learn more and more and more about diabetes, we are finding, and I'm sure other people around the world are finding as well, one of my other big interests is women's health, and in understanding the interaction between women's health and children's health, how women not only impact their own health, but they actually impact the health of the next and maybe a second generation as well. So if you're healthy, it's because your nanny was healthy. So that is an important concept to remember. And so based on that, we're studying gestational diabetes and the impact that gestational diabetes can have in setting up susceptibility in the infant for obesity, for metabolic syndrome. So when you're treating, if you're looking at me at this age and saying, Purnima, you have metabolic syndrome, maybe the treatment should have begun with my mother. And that's where the treatment begins. And so since we can't go back and treat my mother, maybe we should treat me to make sure that my child, if I'm going to have a baby, before I have my child, to treat it. So these are very intricately connected systems, and humans are intricately connected generationally. We are healthy because our ancestors were healthy, and they established this equilibrium between our immune system and the external environment. And therefore, we have to pay it forward by continuing to stay healthy so the next generations continue to stay healthy. So personally, this is great, and I'm so grateful that you have included me in this, because I have a huge interest in understanding the link between type 2 diabetes, T2DM, as well as gestational diabetes and oral health, particularly periodontal health, and the two-way relationship, how events in the mouth can impact glycemic status, as well as how glycemic status impacts oral health. So how can I treat my patients better orally, as well as how can I intervene to send my patients who look iffy straight to my colleagues within endocrinology. So this is a great relationship. And I encourage this group to look beyond diabetes and to start thinking about metabolic syndrome. MET-S has become such a big thing. By the time we get to diabetes, we are far out of this game. So let's start going back in time and start thinking about MET-S and taking it very seriously, because I guarantee you, if 1 in 8 Indians have diabetes, 1 in 3 Indians have MET-S. The masala studies have shown us that the hypercholesteremia studies have shown us that we are at very, very, very high risk for insulin resistance, for hypertension, for hyperlipidemia, and we need to start thinking of that as a precursor. We have done some work on obesity, and I will show you how central obesity also has a role to play in poor oral health at some point. One of these days, or maybe tomorrow in the panel discussion, we can talk about it. But these are very, very important concepts for us to think about. And major congratulations to you for bringing this together, for taking action on it instead of simply sitting around and just saying, oh my God, what are we going to do? So congratulations and best wishes for a fabulous meeting. And again, once again, major thanks to you, Dr. Dheer. Truly, truly grateful to you for this honor and this invitation.
We are humble, ma'am. We are humble to have you over, and it was a pleasure hearing you as always. Yeah, and we reconnect on you, and we hope to see you again back soon. So moving on to the next agenda.
Dr. Sangeeta,
Yeah.
briefly, just I would request Dr. Dominica to give her remarks.
Yeah, Dr. Dominica, can we have your
and
few
then
words,
we have
please?
Dr. Manoj Chawla with us also. Dr. Manoj Chawla, you know that he is a very integral part of Diabetes India, scientific chair of most of the Diabetes India meeting.
Right.
And he is the person who is the first author of the clinical practice guidelines for diabetes and oral health. So we will take his remarks also.
Yeah, absolutely. Dr. Dominica, can we have a word from your end?
Hello, everyone. Can you hear me?
Yes, please.
Thank you so much for the invitation. It's a pleasure to be here. I'm Dominika. Professionally, I'm a dentist. I practice both in the United Kingdom and here in Poland. And 5 years ago, I was diagnosed with type 1 diabetes. And yeah, I can say that I was through it all when it comes to the treatment. I started with MDI. Now I'm using hybrid closed loop system, which I love. And I can say that I'm very passionate about oral health and diabetes. It's a huge passion of mine, and I'm more than happy to be here with you. I had a chance to visit India last year. It's a beautiful country. So now, even if I'm in Poland, I feel a bit like I'm in India with all of you.
So great to hear from you, Dr. Dominica, and sure, certainly in the future, we'll be certainly catching up on the subject. Thank you so much for being here. Dr. Manoj, a very good evening. I think he needs to unmute.
Hi, Dr. Sangeeta.
Hi, good evening, sir. How are you? Can we have a word with you on the subject, please?
Yes. So, well, let me start by congratulating you, Dr. Sangeeta. You are the force behind this meeting.
It's a whole team, sir. Let us congratulate each one of us.
I understand, and I also understand that it requires someone's extra passion to make sure that this kind of correspondence happens and everybody comes together, and which is why I'm congratulating you and the team. This bidirectional link, this aspect of diabetes and oral health, which often doesn't get spoken about and tends to get missed, at least in the physician's office, is something that I have also been involved in the work with, and I'm well aware about the lacunae and the work that needs to be done in this area. And hence, I'm extremely glad about this symposium, this webinar, which is being conducted over the next 2 days, and the planning which has gone behind it. So hopefully, everyone who joins in gains a lot, not only gains a lot in terms of knowledge about this bidirectional link, but actually starts implementing the learnings in their practice towards the aim of improving both the oral health and the diabetes and metabolic control. So once again, I welcome everyone to this symposium and congratulate the team behind it and look forward to the learnings over the next 2 days.
Thank you, Dr. Chawla. Thank you so much for your kind words, and we'll be hearing you tomorrow for your lecture as well. So moving on to the next section, we will be releasing the Diabetes India Oral Health Patient Education Pamphlet very soon. Before that, we do that, allow me to share a few slides on the subject very quickly. So there we go. So what exactly is the patient education pamphlet talking about? To begin with, we will take the pride that Diabetes India took that initial step of releasing the first of its kind patient education pamphlet.
Dr. Dheer, your slides are not on.
Oh, okay. Again a glitch. Again a glitch. Hang on. Sorry. Yeah, am I on page?
Yes.
Okay. So basically the pamphlet, it's like the first of its kind on the subject in India to begin with. curated and created by Diabetes India, because I look at it as an organization which is actually working towards an overall well-being of the diabetic patient. And the synopsis of the pamphlet being like, it is very visually appealing for the patient. It's going to be the colorful designs and graphics representing the clinical stages of the gum disease, that's periodontitis as well, oral complications which are happening in the diabetic mouth, the glycemic levels that should be well versed with the patient, and the prevention and maintenance of the oral health. So in one shell, I would say it's an easy educational tool, both for the dental and diabetology practices in one go. So RX team, can we have the release of the pamphlet, please? That comes later. Anyway, next on the. So I will invite the DI head office, the entire DIOH team, Purnima ma'am, and all the guest faculties out here to just mark your presence. We are just officially releasing for the first time on this webinar. So that's what it looks like.
I'm sure this will be a very useful tool for patient education and awareness.
And a round of applause I must make for our next generation periodontist, Dr. Anupam Dekha. A big, huge round of applause to him, because he has taken a lot of effort in terms of designing this.
Yeah. Thank you.
Thank you, Nilima ma'am. And can we have the certificate of appreciation for Dr. Purnima ma'am? Neela ma'am, RX team. Purnima ma'am, this is a small token of our appreciation for your having a part of this show as a chief guest, and we are humbled and honored to have you here, ma'am. And in the near future, yes, we will definitely have you more times. Thank you so much for your participation, ma'am. Thank you so very much.
Thank you so much. Thank you. Truly appreciate it. Thank you.
Okay, now we bring to the end of the inaugural ceremony, and we are moving on to the scientific sessions. So before we initiate the scientific session, I would like to call upon the chairpersons of the session 1, Dr. Balaji Manohar and Dr. Rakesh Parekh. Kindly make yourself comfortable before we initiate the session. Can we have the intro slide for Dr. Rakesh Parekh, please? Okay, allow me to introduce the chairperson of the first session, Dr. Rakesh Parekh. He is a fellow of American College of Endocrinology, Royal Edge College of Physicians. He's a member of the National Executive Committee of RSSDI. He's a founder, Metabolic Society of Jaipur. He's a recipient of several awards and has been on editorial and review boards for various journals. He has over 70 publications to his credits, with the textbook chapter contributions as well. He's a regular speaker at various diabetes conferences and is a principal investigator on several global phase 3 trials. Can we have the intro slide for the next chairperson, please? Professor Dr. Balaji Manohar. He completed his MDS in periodontology from E.B. Shetty Memorial Institute of Dental Sciences, Bangalore. He's a fellow and member of faculty of Royal College of Physicians, and completed his master's in hospital administration and has a PG diploma in medical legal sciences. He has over 24 years of clinical and teaching experience. He has been the ex-principal and head of department of KIDS Bhubaneswar and has served ISP in several categories. He's served as Indian Dental Association also in various capacities, and is an examiner for UG and PG program, and is a PhD guide at the Rajiv Gandhi University of Health Sciences. Over to the chairman. Can I request Dr. Rakesh Parekh to kindly introduce the first speaker of the day, Dr. Anupam Dekha, please.
Thank you, Dr. Dheer, and thanks for organizing this wonderful event, which will be definitely a learning for at least the diabetologist community, because we often don't hear the talks which are on oral health. And I can see there are so many luminaries from the field of dental health. So it will be a good learning experience for us. Can I have the slide of the first speaker? First speaker, please. Yeah. So the first session will be by Dr. Anupam Dekha. He is MDS in periodontology, and he is a reader at Department of Periodontics and Oral Implantology, Regional Dental College, Guwahati. He did his MDS in periodontology from Regional Dental College, Guwahati. He was a former lecturer at Buddha Institute of Dental Sciences and Hospital Patna. He has presented papers at national conferences of Indian Society of Periodontology and has been a guest speaker at various conferences and continuous dental education programs. He is a visiting consultant in Nemcare Super Specialty Hospital, Guwahati, and he is a committee member of Diabetes India Oral Health Group. Over to you, Dr. Anupam.
Thank you so much, sir. Thank you so much for the kind introduction, sir. Yeah. So,
Dr. Anupam, there is some
esteemed
echo.
chief guest.
If there are two devices, I think you have to. There is some echo.
Yes, sir. Okay. Excuse Sangeeta, madam.
Yes, please.
I think someone has to share my slides. Actually, I'm unable to do that. So
Yeah,
that
we will. We will tell the Neelima ma'am. Please share Dr. Anupam's slides, please.
Neela, better give him the rights for sharing the slides so that he can share himself.
No, we have already told them. So, Neelima ma'am.
Yes, ma'am.
Kindly share his slides.
Yeah, thank you so much.
Please go ahead. Yeah.
Am I audible, ma'am?
Yes.
Yes. So, esteemed chief guest, Dr. Purnima Kumar, madam, respected chairperson, Dr. Balaji Manohar, sir, and Dr. Rakesh Parikh, sir, respected moderator, Dr. Sangeeta Dhir, madam, and very welcome delegates. It is indeed a matter of I am honored to be presenting this first introductory speech lecture of the first webinar of Diabetes India Oral Health Group amidst this galaxy of eminent academicians, clinicians, and various specialties. So, next slide, please. Yeah, periodontal disease and diabetes, these are both chronic and highly prevalent, coexistent comorbid conditions in the general population. The current scientific evidence suggests a bidirectional association between oral health and diabetes and a mutual reciprocal increase in the risk incidence, prevalence, progression, and severity has been documented for both diseases. Next. So an introduction about periodontal disease. We are all experienced as periodontists. We are all experienced with periodontal disease. So periodontal disease is an inflammatory disease which is caused by bacterial plaque. So initially it starts out as gingivitis, and the most prominent sign of gingivitis is bleeding on probing. So the clinician, when he checks the patient, it's a clinical sign when he puts the probe there and there's bleeding on probing. Sometimes it is also presented, reported by the patient as bleeding on brushing. Then there might be changes in the color of the gingiva, then different sizes, surface texture, and consistency. One important characteristic of this gingival and periodontal disease is that it's a chronic inflammatory condition. And when it is unchecked or treatment is not done, then we can even find changes in position and destruction of the underlying periodontal structures. Next, please. So this slide shows the early stage of gingivitis, and in the advanced stage, we have loss of attachment. And in advanced cases of loss of attachment, there is bone loss, and there might be mobility of the teeth, spacing of teeth, and ultimately tooth loss might be there. Next. So the disease may progress rapidly or slowly and has been presently categorized in stages and grades according to the severity of the periodontal destruction and risks of disease progression respectively. This is from the 2017 World Workshop on the Classification of Periodontal and Peri-implant diseases and conditions. Now, this staging and grading is very relevant in case of relation to diabetes, which we will see in subsequent slides. Next. So the periodontal bacteria, which are there in the periodontal pocket, these have ready access to the circulation. And subgingival, especially gram-negative bacteria, they go into the circulation and cause a lot of problems for different disease, different organ systems like heart disease, respiratory infections, preterm, low birth weight, etc. And one of the main conditions which it affects is uncontrolled diabetes. And in case of diabetes, there is a bidirectional link between the periodontal disease and diabetes. Next. Next, please. Yes. So coming to diabetes mellitus, there are so many experts in this, so I'll not go into detail with diabetes. It's basically a heterogeneous syndrome with impaired glucose tolerance and impaired lipid and carbohydrate metabolism. So basically three types. Type 1, this is insulin-dependent diabetes mellitus. It's an autoimmune disease which destroys the islet cells of Langerhans of the pancreas. Then non-insulin dependent diabetes mellitus, which is the most common version. And we have a transient condition like gestational diabetes, which appears in pregnancy, and after birth, usually it subsides. Next. So these are the blood glucose level status. This is given by Research Society for the Study of Diabetes in India and Endocrine Society of India jointly. They have given this. So the fasting blood glucose 7 to 90 milligram per deciliter, hemoglobin A1C less than 5.7%, and less than 140 milligram per deciliter postprandial blood glucose, that is normal. Then in case of pre-diabetes, 100 to 125 milligram per deciliter fasting, HbA1c 5.7% to 6.4%, and BP 140 to 199 milligram per deciliter. And in diabetes, fasting blood glucose, usually it's seen to be more than 126 milligram per deciliter, HbA1c more than 6.4%, and PP is more than 199 milligram per deciliter. Here, I would like to highlight the fact that this pre-diabetes, this is like a silent epidemic because so many patients, they are going undiagnosed of this condition, and eventually they develop into diabetes. Next, please. So some of the common signs and symptoms of diabetes: increased hunger, increased thirst, frequent urination, polyuria, polydipsia, those are classical symptoms. Polyphagia, then altered wound healing, easy fatigue, then weight loss, unexplained weight loss. Next. There is a saying, a common saying, that misery loves company. If a disease condition is there, it usually attracts other disease conditions also. And nowhere it is more true than in case of periodontal disease and diabetes. Next, please. So this bidirectional relationship between diabetes and many other inflammatory conditions such as periodontal disease are owing to several pathogenic mechanisms. Especially three pathogenic mechanisms are seen, like bacteremia, inflammatory response, and the immune response. Next. So this two-way relationship, it is well documented that this awareness of this relationship between the periodontal disease and diabetes has not been included in the medical education curriculum in India, nor any formal and serious attention has been imparted in clinical world and its academic activities. Next, please. But that does not mean that there is no evidence. There is a lot of scientific evidence right from this case reports to randomized clinical trials and meta-analysis, which has time and again showed the relationship between periodontal disease and diabetes and how each other affects, and the effect of periodontal therapy on the glucose level has evidently been shown to come down. Next. So this picture, ever since as an undergraduate student in Karanza, this picture had always made an impact on me. So this was like an unforgettable picture where they have shown that the total surface area of the pocket lining of a generalized moderate chronic periodontitis patient, the total surface area comes to around 2 centimeters, which is like the average size of the human palm. That means a patient with chronic periodontitis generalized is moving around with a chronically infected and inflamed wound. And if that patient has diabetes, then things will definitely get more complicated. And this same wound, this same size wound, if it were to be present in another area of the body, a visible area of the body, then no doctor would have ignored that. And even the patient would not ignore it. But since it is inside the mouth, it is not visible. And the periodontal disease, usually there are no acute symptoms, no symptoms to which the patient is forced to seek treatment. So this complicates the matter further. Next. So some complications of diabetes mellitus, the classical complications: retinopathy, nephropathy, neuropathy, macrovascular disease, altered wound healing. Next. Next, of course, is periodontal disease. That is known as the sixth complication of diabetes. Next. And as a sixth complication of diabetes, this has been said by ADA. ADA in this case is not American Dental Association, but American Diabetes Association. So this is actually good news for us that this article first appeared in the journal Diabetes Care. It was way back in 1993. And in fact, in 2009, American Diabetes Association, in their standards of medical care, has suggested that any patient, diabetic patient, which has been treated by physician, they should always be referred to a dental surgeon. Next. So this chart shows what periodontal disease means for a patient with diabetes. First, a patient with diabetes has more incidence of periodontal breakdown, attachment loss, and especially multiple periodontal abscesses are seen in patients, periodontal patients who has diabetes. Now, this chart shows severe periodontitis and moderate periodontitis and healthy and gingivitis, where they have shown that the hemoglobin A1C is definitely poor in case of severe periodontitis. Similarly, in case of CRP levels, in case of severe periodontitis, that is seen to be the highest. And on the other hand, interleukin-10, which is an anti-inflammatory cytokine, that level is the lowest in case of severe periodontitis, and it is highest in case of health or in gingivitis. So as we see that as the situation from health to disease progresses, then similarly, the CRP level and the HbA1c, CRP level rises, the glucose HbA1c also rises, plus the anti-inflammatory cytokines, they become less. Next. So this is given by International Diabetes Federation statistics about the prevalence of diabetes that shows a very disheartening statistics, like it is projected that in 2030 there will be 643 million diabetic patients in the world, because in 2001 it was 537, and in 2040 it is projected to be 642, and in 2045 to 783 million diabetic patients in the world. Next. Similarly, in case of top 10 countries or territories for number of adults within the age group of 20 to 79 years in diabetes in 2021 and projected to 2045, in India, it is in second with 74.2 million diabetic patients. So definitely we have this ignominy of diabetes being called India being called the diabetes capital of the world. Next. The burden of periodontal disease, 35 to 44 years, chronic periodontitis usually is seen most in this age group. It is seen to be maximum in 80% of the people with 35 to 44 age group is seen to be having this kind of problem. Next. The consensus report of work group 2 of the World Workshop on the Classification of Periodontal and Peri-implant Diseases and Conditions. Next. Here, what they have shown is that this is a part of the classification where they have shown the grade periodontitis. If the patient has diabetes, then it is a risk factor which changes the grade from grade B to grade C. That means a patient normally, if suppose a patient with moderate clinical attachment loss was in stage 2, if that same patient were to have diabetes, then automatically the patient will be shifted to grade C. Next. So some other oral complications in diabetes, apart from periodontal disease, mouth ulcers, dental caries, dry mouth, and next. So the periodontal disease is present in as many as 80% of people aged 35 years, and diabetes affects around 8 to 12% of the Indian population. In any district of India, as many as 35 to 40% of people can be classified as suffering from metabolic syndrome or pre-diabetes. So next. So that means that the diabetes and periodontal disease have a common enemy, and the common enemy is you. You means actually it should actually be us. That means it's the general population, the patients, doctors, physicians. No one is exempt from the risks of this disease. Next. So poor glucose control raises the risks of oral health challenges, and oral health challenges can lead to poor blood glucose control and higher risks of diabetes and related complications. Next. As I had mentioned earlier, misery loves company, but to triumph over that, it demands an audience. An audience in this case is the general population, the all the stakeholders, the different experts of different specialties, dentists, clinicians, academics, etc. Next. And webinars like this, these will go a long way in forming a collaboration among this interprofessional collaboration between periodontists, diabetologists. This provides them an opportunity to render improvised, effective, and optimal patient care for an increasing number of patients with periodontal disease or diabetes, or both, in daily clinical practice. Next. So this collaborative clinical practice will have a significant improvement in oral health quality of life of periodontal disease and diabetes patients. The oral healthcare team plays an important role in the identification of both prediabetes and undiagnosed diabetes mellitus patients, and the physicians need to be aware of periodontal diseases and their implications for glycemic control and complications in patients with diabetes. Next. So a start has been made with our group, Diabetes India Oral Health Group, and Indian Society of Periodontology and Research Society for the Study of Diabetes in India. They have also joined hands to form, to come out with good clinical practice guidelines and consensus reports. Next. So these two articles have been the basis of my reference for these lectures, the good clinical practice and a consensus report of ISP and RSD. Next. So I would like to acknowledge Diabetes India Oral Health Group and all the members of the group, and especially Dr. Sangeeta Dhir Madam. And thank you so much for giving me this opportunity to present this lecture. Thank you.
Thank you, Anupam, for that lovely page that you have set up for the show. Thank you so much.
Thank you,
may I now invite Dr. Rakesh Parekh to introduce the next speaker, Dr. Sumedha Bansal.
Yeah.
Can we have Dr. Sumedha's slide, please?
That was really an enlightening session, at least for the people from diabetes community. Now we move on to the second speaker, Dr. Sumedha Bansal. She is again a MDS in periodontology, senior consultant in Department of Dentistry, Accord Hospital, Faridabad, Haryana. She did her master's in periodontology from Pandit B.D. Sharma University of Health Sciences, Rohtak, Haryana. She is ex-professor of Sudha Rastangi College of Dental Sciences, Faridabad, Haryana. She has over 15 years of experience in academics and clinical practice. She has numerous publications to her credit. She is a co-chair of Diabetes India Oral Health Group, and her areas of interest are periodontitis and diabetes, periodontitis and preterm low birth weight. Over to you, Dr. Sumedha.
Thank you, sir. Thank you so much for the introduction. Just a second.
Just go to full screen. Huh? Down. Go down on the full screen.
Yeah. So a very good evening to one and all. I thank you all for your time, and I thank DIOH for giving me this opportunity to share my knowledge in such an august gathering. I'll be talking about the pathomechanisms linking diabetes and periodontitis. As we all know, and more adeptly, our esteemed physicians recognize that oral cavity reflects signs of nutritional deficiencies, endocrine imbalance, GI disturbance, blood dyscrasias, etc. And maybe that is the reason why these questions have been doing the rounds since the time of focal infection theory. Can oral disease have an effect on the system and vice versa? That is, does the system impact the oral cavity? In relation to this to these questions, numerous scientific research are being published every year since past 30 to 40 years. It started with the association between periodontal pathogens and systemic diseases, and now has burgeoned into a complete branch of periodontal medicine, which has bit by bit gathered evidence enough to prove a two-way relationship between diabetes and oral diseases. Now, let us just quickly go through the oral manifestations of diabetes, like mucosal disorders like lichen planus, delayed wound healing, dental caries, fungal infections, fissured tongue, altered taste, salivary gland dysfunction, xerostomia, burning mouth syndrome, and last but not the least, periodontitis and periodontal and gingival abscesses. Now, the reason can be owed to immune dysfunction, peripheral neuropathy, or the drugs that the patient is taking. All of these are not pathognomic and are very less likely to be present in well-controlled diabetics. Now, we have a pictorial representation for more clarity. It clockwise shows lichen planus, fissured tongue, angular cheilitis, denture stomatitis. Here we see periodontitis, which can sometimes represent in the form of recession and spacing between the teeth. This pic also shows caries and calculus. And on the right side, we see periodontal abscess in the form of gum swelling. For the better acquaintance of our medical colleagues, let me just explain periodontitis in short. Periodontitis is characterized by microbially associated host-mediated inflammation that results in loss of periodontal attachment and destruction of supporting tissues. And on the right side, we can see the pics also, like healthy gum tissue, how does that look like? And in gingivitis, we see red and swollen gingiva. In periodontitis, we can see pockets also, and bone loss has started. And in advanced periodontitis, there is advanced bone loss. So it's a highly prevalent disease with almost 60% prevalence rate and 10 to 15% of these suffering from severe form of disease. Diabetes is a major risk factor with almost 3 times susceptibility increase of periodontitis in diabetes. On the other hand, risk of diabetic complications like macroglobinuria, end-stage renal disease, and cardiorenal mortality increases 2 to 3 times in diabetics and in periodontitis as compared to diabetics without periodontitis. So this is a consensus report of joint EFP and AAP workshop, that is the European Federation of Periodontology and American Academy of Periodontology, which was published in 2013, which reported that mechanical periodontal therapy is associated with 0.4% reduction in HbA1c at 3 months, a clinical impact equivalent to adding a second drug to the pharmacological regime for diabetes. Not only that, consensus report and guidelines of joint workshop of periodontal diseases and diabetes by IDF, that is the International Diabetes Federation, and EFP, that is the European Federation of Periodontology, got published in 2018, which reiterated the findings of the former report and laid down guidelines for physicians, oral healthcare professionals, and patients to improve early diagnosis, prevention, and co-management of diabetes and periodontitis. Now, just let us quickly run through this video to understand the relationship better.
Periodontitis is inflammation of the gums and supporting structures of the teeth. If untreated, it causes tooth loss. Did you know that periodontitis and diabetes are closely linked? People with periodontitis are more likely to develop diabetes, and vice versa. Diabetes increases the prevalence, progression, and severity of periodontitis, and periodontitis influences blood sugar control in diabetes. The good news is that periodontitis is easy to diagnose and control. Keep the following tips in mind. To prevent gum disease, seek advice from your dental care professional twice a year. Early treatment of periodontitis may reduce the risk of prediabetes.
Now, moving on to the pathomechanisms. First, let us consider the biologic mechanism of diabetes in periodontitis patient, or the effect of periodontitis on hyperglycemia. As we know, that periodontitis is a chronic inflammatory disease in which inflammation of the periodontal tissues is stimulated by long-term presence of subgingival biofilm. This inflammatory process is characterized by dysregulated secretion of host-derived mediators of inflammation and stimulation of inflammatory cells which act locally to result in destruction of supporting tissues. These mediators are increased systemically also. So that causes a generalized systemic inflammation and which can lead to increased insulin resistance, thus contributing to hyperglycemia and eventual complications. For more understanding, let's go through this flow chart. Once chronic periodontitis gets initiated, there is a systemic inflammation and a rise in inflammatory mediators, especially TNF-alpha, which creates inhibition of tyrosine phosphorylation of insulin receptor, leading to insulin resistance and poor glycemic control. Now, since periodontitis and resulting inflammation cause insulin resistance, reducing this inflammation might revert it also. And yes, that is what published data suggests, that up to 0.4% HbA1c reductions can be expected. And let me share this fact also, that every reduction, 1% reduction in HbA1c levels, there's an associated 25% reduction in diabetic complications. So now let us see the other way around. Biologic mechanisms of periodontitis in diabetic patients, or effect of diabetes on gum health. Now, the relation between oral microbiota and diabetes has been noted by many scientists. And a study was published in 2015 by Demer et al. That even proposed that changes in glucose metabolism affects flora to the extent of developing de novo periodontitis. A systematic review published in 2021 demonstrated association of diabetes mellitus with significant change in subgingival flora in both periodontitis as well as non-periodontitis individuals. The flora was found to be belonging to red complex, namely T. denticola, B. forsythensis, and P. gingivalis, which are the main periodontopathogens, which were higher in numbers in poorly controlled diabetics, as well as compared to non-diabetics and well-controlled diabetics. So after learning the effect on flora, let's see the effect of diabetes on inflammatory burden. So the GCF in diabetic patients shows increased level of TNF alpha and interleukins, interleukin 6, interleukin 1 beta, interleukin 17, and many such inflammatory mediators. Cytokines are also produced by adipose tissues, that is adipokines like viscetin and leptin. And higher expression of pro-inflammatory cytokines causes activation of Th17 pathway, which has a role in bone resorption and rank L production. This inflammatory state affects cellular response, like local fibroblasts also initiate secretion of high levels of TNF alpha, and they also show apoptosis. Now, a study by Hung et al. Showed in his immunological study that high glucose enhanced inflammatory response induced by P. gingivalis lipopolysaccharides. Now, advanced glycation end products. We know that hyperglycemia causes the production of irreversible advanced glycation end products due to the enzymatic glycosylation of glycation of the proteins. So these have a direct pro-inflammatory and pro-oxidant effect on the cells. Age's cross-linked collagen make it less soluble, less likely to be replaced or repaired. So overall, we can see that there is an altered collagen metabolism. Collagen becomes aged and more susceptible to breakdown. Cellular migration is impeded and tissue integrity is impaired. Thickening of basement membrane of vessels impairs oxygen diffusion and PMN migration. Possible association has been found between ages, that is advanced glycation end products, and inflammatory response of the periodontal ligament cells, which again leads to hard and soft tissue destruction. Let's elaborate with the help of a flow chart. Ages have an effect on various cells. Their effect on endothelial cells causes increased permeability and molecule adhesion, while their effect on fibroblasts that causes decreased proliferation, decreased collagen production, and increased apoptosis. And both of them, they cause impaired wound healing and susceptibility to infection. On the other hand, ages have an effect on macrophages also, because of which the cells become hyperactive with increased production of TNF alpha and interleukin 1 beta. And the effect on PMNs is also drastic. That is, there is defective chemotaxis and phagocytosis. So an association between high glucose levels and increase in apoptosis in cultured periodontal fibroblasts have also been reported. Now coming on to age and RAGE interaction. Age is advanced glycation end products, and RAGE is the receptor for ages. So when age will bind to RAGE, then enhanced inflammation and oxidative stress is there. Further age formation is there, and this causes impaired tissue repair. And it has also been seen that if RAGE, that is the receptor, is blocked, then there is a decrease in inflammatory cytokines. But their interaction produces reactive oxygen species, enhancing oxidative stress and subsequent endothelial cell damage and vascular injury, increase in respiratory burst in PMNs causing local tissue damage, detrimental effect on bone metabolism, impaired repair and bone formation. Now let us see the effect of inflammation on bone homeostasis. The receptor that is RANK, which is present on osteoclast, that is the receptor activator of nuclear factor kappa B, that is present on the nucleoclast, and its ligand that is secreted by T cells. When both of them combine, then there's an increase in bone resorption. OPG is an antagonist of RANK-L, and when this combines with RANK, which is present on the osteoclast, then there's a decrease in bone resorption. But in diabetic patients, what we have seen is that the GCF RANK-L and RANK-L to OPG ratio, they are higher in poorly controlled diabetics than well-controlled, and increased free fatty acid levels in diabetics may also increase osteoclastogenesis via elevated levels of TNF-alpha. Age may increase osteoclast activity as shown in animal studies. So studies have shown that RANK-L cells presence increases in diabetes, and that severity of periodontal tissue breakdown correlates with severity of diabetes. So now it's the time to summarize. Hyperglycemia affects the local environment. There may be increase in GCF glucose levels, which may alter a periodontally healthy flora into a diseased one. Then hyperglycemia causes age formation, which further leads to these effects like impaired cellular functions, vascular alterations, prolonged inflammation, impaired bone formation, and impaired wound healing. And ages and hyperglycemia, they both have an effect on the cells, because of which there can be increased MMPs, increased apoptosis, and oxidative stress, while there can be a decrease in collagen synthesis, chemotaxis, growth factors, and overall or extracellular matrix also, all leading to destructive disease like periodontal disease. So this flowchart finally depicts how there is enhanced tissue destruction and impaired tissue repair in diabetes, which may lead to periodontitis. So finally, to conclude, the bidirectional relationship between diabetes and periodontitis is based on changes in microbiome towards dysbiotic state, direct changes in host immune system as a result of hyperglycemia, and hyperglycemia itself. It promotes pro-inflammatory response in periodontal environment via direct path and via age-range axis, which further supports catabolic cellular functions, expressions of pro-inflammatory cytokines, and alteration in RANK-L-OPG ratio, promoting bone resorption and overall tissue destruction. So finally, I would like to thank DIOH for giving me this opportunity to present and share my knowledge with you all. So together we are stronger, our voice is louder, and synergy of our actions more powerful. Thank you so much for patient listening.
Well said, Sumedha. It was a lovely presentation. Now we move on to the last speaker of the session, and we request Dr. Balaji Manohar to kindly introduce the next speaker, Dr. Amit Gupta, please.
Can you hear me?
Yeah.
Thank you. Thank you, Dr. Sangeeta. Thank you, DI and RSDI for having invited me to be here amongst you. We have already heard Dr. Amit earlier also, but doing a formal introduction, it's my proud privilege to introduce Dr. Amit Gupta over here. Dr. Amit is a member of the advisory group for the American Diabetes Association for the year 21-22, and also is advisor to ADA's Public Health and Epidemiology Interest Group 22-24. He's an executive council member of the National RSSDI and ACP India chapter, and we all know that he is the Joint Secretary of Diabetes India and UPDA. Apex body member of the Art of Living Trust 2019 to 2020-21. He is a reviewer for endocrine practice, AAC case reports, clinical diabetology, IJDDC, and MKSAP 19. He is the executive editor for the Sadikot International Textbook of Diabetes, the second edition, the RSSDI Proceedings 2022, and is also having more than 40 national and international publications to his credit. He is the program coordinator for the RSSDI Save the Feet, Keep Walking campaign, RSSDI Rotary 100 Village NCD project, Defeat Diabetes campaign of the RSSDI, and Project IRIS of ACP India chapter, ACP India case files. Also, to his credit, he is having quite a few awards. He is a proud recipient of Diabetes Tech Innovation Award for the year 2022, DiaCare Award for leading most successful diabetes campaign 2021, ACP India Chapter Community Teaching Award 2021, Times of India Health Icon Award 2021, Diabetes Excellence Award 2021, National Health Award for the year 2016, Diabetes Awareness Initiative Award for 2017. And also he is a proud recipient 3 years continuously for the year 17, 18, and 19 Investigator of the Year Award. Also, lastly but not least, Padmakar Tripathi Young Scientist Award for the year 2017. We have with us Dr. Amit, who is going to speak to us on what is the consensus on periodontal disease and diabetes in India, the ISP RSSDI guideline. Dr. Amit, the stage is all yours.
Thank you, Dr. Balaji, for the kind introduction. And with your permission, I would like to share my screen. And I think
Please
the
go
ball
ahead.
is already being set, rolling by the two previous speakers who have talked about the periodontal diseases, their connection with the diabetes, and the other aspects. So I think it is important to highlight that diabetes and periodontitis and the other problems, they exist together. And so I think it started in 2019 when we get the first opportunity to join hands with the Indian Society of Periodontology, and RSSDA came together and we had a symposium in Delhi. And this was the consensus statement that came out of the symposium, and this report of the ISP as well as the RSSDI, which was a joint initiative on periodontitis and diabetes. And these are the authors who were part of that publication. And again, it was an effort by Dr. Sangeeta Dheer and from then RSSDI executive team from Delhi. So what we discussed, we found that the diabetes and periodontal diseases, they are chronic inflammatory conditions, and they have many common factors as risk factors. And there is a bidirectional relationship between these two diseases, which are very, very important to address. And this means that people with diabetes, they are at a higher risk of periodontal diseases, and severe periodontitis leads to poor glycemic control. So poor dental health, poor glycemic control, more poor dental health. So both the diseases are common and they have high prevalence rate, and they are becoming clinically complex with aging. So the periodontal disease is present in as many as 80% of the people aged above 35 years. So again, this is a very large percentage of population. And as our respected chief guest rightly pointed out, that we are facing the burden of metabolic syndrome. So I think that, again, we are having a huge population burden of periodontal disorders. And diabetes affects around 8 to 12% of the urban Indian population. So in any district of India, as many as 35 to 40% of the people, they can be classified as suffering from metabolic syndrome or prediabetes, and as very rightly pointed out by previous speakers. The complexities of the treatment and the success in the management and the prognostic implications, they are again very seriously compromised when both these conditions they coexist. And you can easily imagine that what will happen to the health burden, economic cost, and we are now more than 100 million people living with diabetes in India. It is also very well documented that awareness of this bidirectional relationship between periodontal diseases, oral health problems, and diabetes is neither included in the medical education curriculum in India. So we are not focusing on the oral health and the dental part of it, and probably the dental community is not focusing on the management of diabetes. And this one of its own kind of association stands out to be the first of its kind in India. Itself tells us that we are so late in developing this kind of association. So during that seminar, which was held in 8th of September 2019 in India, more than 150 delegates from different faculties, they attended the program. And this is one of the photographs which was taken during that program. And you can see Dr. Sangeeta leading from the front, Dr. Sumedha also, and many of the renowned people from the field of diabetes as well as the dentistry were there. And 7 conclusive points of agreement were that people with pre-diabetes and diabetes have higher chances of developing dental disorders, and those who have higher chances of and those with periodontitis, they have higher chance of developing pre-diabetes and type 2 diabetes. So this was one of the agreement and the conclusion which we reached after that meeting. That's yes, there is a link, and it doesn't need more evidence that there is a bidirectional relationship between the two. Again, the second consensus was that the causality between the gingival microbiome and diabetes, though remains unproven, but periodontal microbiome does get affected, altered in the presence of hyperglycemia. So there is a direct causal association. There is a lack of evidence for that, but it is very well documented and demonstrated that hyperglycemia can alter the presence of periodontal microbiome in a way that is more harmful for systemic inflammation. Another important consensus that was reached was that there is enough validation for diabetes and its complications getting increased or exacerbated in the presence of periodontitis, but the fact that the certain biological mechanisms do mediate the negative effects of periodontitis on the control of diabetes. And newer biological evidences also emphasize the role of lipid imbalance in the exacerbation of both the diseases through the role of cytokines. And this was very scientifically depicted by Dr. Someda in her slides. The few more points where we reached consensus is that the chronic inflammatory state, which contributes to pathophysiology of diabetes as well as its prognosis, also gets seriously exacerbated in the presence of periodontitis. So it is there is an you can say the inflammation increases in the presence of dental inflammation. Again, there is a improving the if you improve the glycemia, there is a greater likelihood that the periodontal health will improve. So there is no dispute regarding that. And the clinicians of the respective specialties, they should fully acknowledge and understand the gravity of diabetes and its associated risk with periodontitis and vice versa. So this forum again signifies the importance of two different specialties coming together to address the common problem which is affecting both of them. So we, at that point of time, also agreed that the lacuna of understanding and practice about the two diseases association needs to be addressed. And that is why we are here. And a set of practice guidelines must be developed and incorporated as formal publication by the respective societies. So this was in 2019. And this was the future directions which were given for the clinical practice and research, but I will not go into the detail of that. So it was thought that more public awareness is needed, more and more educational activities, CMEs, seminar, conferences, where we talk about this bidirectional relationship is actually required, because this is a neglected subject in both the fraternities. And again, the public awareness needs to be heightened about this very, very important problem. So few other points which can be done is that we can do collaboration where we can talk about data collection. We can think about different ways how we can generate more evidence about this association and how this association can be changed into a positive impact when it comes to glycemic control as well as the dental health or the oral health problem is addressed. So here comes 2020, and this is a very, very important paper. And this is the management of periodontal disease in patients with diabetes. What are the good clinical practice guidelines? And this was a joint statement by the Indian Society of Periodontology and the RSSDI. I think this is a document, again, talks about the seriousness in the community to address this relationship. And Dr. Manoj Chawla, who was already here, was part of this author guideline from the RSSDI, and I could see many names from the ISP. So I have taken only few important points, though the entire part of the document is important, but it is difficult to discuss in 15 minutes. So I thought, let me take out few features or the silent features which may be important for everyone. The document talks about the diagnosis of diabetes. Document talks about various risk factors for diabetes, how it should be managed, how the insulin should be titrated. But I thought it would be important because it is a joint meeting of fraternity from the dentistry as well as the diabetologist. So whenever you are, especially for my dental colleagues, if you are seeing a patient in your dental chair and you find that this patient is a male patient more than 45 years of age, there is a strong family history of diabetes, is having a sedentary lifestyle, physical activity, which is more than less than 3 times a week, obese, and there is an increased waist circumference. And if you are able to calculate the weight and the height, then you would know the BMI. If the BMI is increased, and in female patient, especially, you would like to understand, is there any history of gestational diabetes or having delivered a child with a very large birth weight at the time of birth. So all these are the risk factors that you may suspect that this patient is having diabetes, can be at risk of developing diabetes, or may already be having diabetes. So whenever your patient is having these kind of characteristics, it is important to look especially into the history of diabetes, and it is prudent to check for the diabetes in these patients. Again, when this document was produced in 2020, the risk factor 45 plus was something which was considered as a risk factor for diabetes. But now the newer guidelines, including the ADA, RSSDI, ICMR, they say that even if there is a family history of diabetes, person is obese, overweight, then you do screen for blood sugar even after the age of 18 years. So the age is no bar. Wherever there are multiple risk factors like obesity, lack of physical activity, sedentary lifestyle, waist hip ratio, waist circumference, the increased BMI, and strong family history, we should not hesitate in screening these people for the presence of diabetes. Another important thing is that whenever a dental practitioner is doing a diagnostic workup and you are finding that a person is having increased blood pressure, do check the blood sugar also. Somebody who is complaining of sudden weight loss. Sudden weight loss may be a very, very common problem in people with dental disorders, because sometimes with poor dentition and everything, these people may not be able to eat much. And because of the poor eating, and they may be losing weight. But diabetes can also be responsible for sudden weight loss. So this is something which should be kept in mind. Symptoms like malaise, weakness, increased frequency of urination at night, and especially in young children and youth, the history of bedwetting, dry mouth, drowsiness, all these again sometimes are the symptoms where you should think of that these patients can be at high risk of blood sugar or already be having diabetes. Oral signs of diabetes, this is a part of the statement itself. And you know that many of these things have already been shown in the form of images by Dr. Sumedha in his slide, and Dr. Deka also talked about this. So whenever looking at the oral cavity, we are finding that there is a severe periodontal destruction, and which can be seen as an increased periodontal pocket depths, bone loss, and progressive attachment loss. If you find that there are multiple acute abscesses, and you find there is suppuration from the pockets, or there are increased sites where already more than phase 1 therapy has been done. If you find the candida-related oral lesions like angular cheilitis, median rhomboid glossitis, erythematous stomatitis, so all these are oral signs of diabetes, that somebody may be having hyperglycemia, and that may be at the root of all these problems. Sometimes tongue abnormalities like fisher tongue, ball tongue, geographic tongue can be because of diabetes. And bad breath, which is, or the ketone breath, halitosis, typically fishy smell, dry sockets, and oral lichen planus, and the pain, discomfort, burning sensation, and the sensitivity to the acidic food. All these can be oral signs of diabetes. So whenever a patient is coming to dental community with these problems, or whenever we, as a physician, we are seeing all these problems as a examination of the general physical examination and the examination of the oral cavity, then it can be a good window to the systemic health, and we can very well predict that this patient can be at risk of developing diabetes or may already be having diabetes. So what are the recommendations which were put out by this esteemed group? So periodontal therapy should aim to achieve clinical gingival health through active treatment and frequent periodontal maintenance. The true therapeutic endpoint for successful therapy is maintenance of at least 20 teeth in the oral cavity. This is a WHO health goal without active periodontal disease. And the achievement of periodontal stability is an acceptable treatment outcome that would require a synergistic partnership of a dental practitioner in consultation with a medical counterpart on a compliant patient. In medically compromised state, active therapy, and frequent periodontal maintenance should be able to achieve disease control and remission stage. It is to be remembered that this stage is very unstable and would require more aggressive and subjectively tailored recall programs. Another important thing is that these patients will require very strict glycemic control. So systemic complications, they require a hand-in-hand approach between dentists and physicians as treatment goals and outcomes are interrelated. So again, the document emphasizes that we should work hand in hand so that our patients get maximum benefit in terms of glycemic control as well as the oral health. And the balance between the medical and perceived periodontal treatment needs should be reached based on comprehensive quality of life assessment. So with this, I would like to thank all of you for your patience listening, and I will hand it back to the respected chairpersons and Dr. Sangeeta.
Thank you, Dr. Amit. That was a very crisp presentation on the interrelationship of the perio disease and diabetes, and the consensus report which we in 2019 and the practice guidelines which was brought out in 2020 have been come out. I do not see any questions as yet in the chat box, neither on the YouTube channel. Both sides, there are no questions as yet. But I invite anybody who is listening to us right now here, if they have any questions and they have not put up in the chat box, are welcome to put the questions here. Anybody can raise the hand and we can take up. And probably Dr. Dominica also is here. Maybe she can throw some light because she said she's also suffering having diabetes. So if she wants to put in a couple of words on this.
Thank you. So from patients' experience, I think it's really important to underscore, especially to those who are on multiple daily injections, what they should do after hypoglycemia event at night. This is actually the topic of my master's thesis at Swansea, when I've asked the other people with diabetes whether they do anything after experiencing hypoglycemia at night. Because when I was diagnosed, I remember that in my case, it happened quite often. And it was just bothering with me because, you know, it was like at 3 a.m. in the morning, then again, 5 a.m. in the morning, I was sitting there in my bed, drinking orange juice or eating jelly babies. After hypoglycemia, I was feeling very tired, and I was just wondering whether there's anyone in the world who is actually motivated enough to do anything related to their oral health. And as a dentist, I felt really guilty because I was aware of the consequences that sugar and acid has on the enamel of the teeth. So I was just wondering what are the behaviors of the other people? And I asked them, and among 2018 answers, there was a minority of the people who'd done really anything related to their oral health after the hypo, while I think we should aim to recommend a simple habit to just rinse their mouth, either with the water or with a mouth rinse which contains fluoride, because immediate brushing after the acid consumption is contraindicated as well, because it can wear off the enamel. So, you know, just a simple habit of having a glass with the water or a mouth rinse that contains fluoride could be a good way for prevention and to limit the development of caries among these individuals in the future.
Oh, thank you, Dr. Dominica. Thank you very much. Anybody else? Yeah.
Just one more thing, and I think for us, the dentists, it's also very important to ask our patients about their hypoglycemia awareness, so they can describe their hypo symptoms. I'm not sure whether every single dentist is actually aware how the hypoglycemia can look like, and it also differs among individuals. So I think in order to provide safer dental visit, it's really a crucial question.
Yes, we do ask our patients what if they are suffering from diabetes or anything like that. Nowadays, it's become very common for the dentists to ask their patients about their diabetic and glycemic status. Thank you very much, Dr. Dominica. Anybody else over here?
Dr. Balaji, I would like to highlight one important point that most of the time, I think very few physicians may be referring the patients with diabetes for the oral health thing. So this is a big challenge, I think, because at the time whenever we are consulting the patient, we are more focused on the glycemia, hypertension, CV risk, and the dental care or the oral health care takes a backseat in a physician's channel. So I think more and more awareness is needed on that. And second important thing is that you may be seeing a lot of patients with oral health issues, and they may also be having a diabetes. But we are getting the referrals most of the time whenever some surgical procedure is planned. Right. So whenever a dental dentist is concerned with the glycemia, it is only the procedure point of time. Otherwise, the referrals to a physician is not for the glycemic management, but only when there is a very strict indication that, oh, we need to do surgical procedures. So now we cannot do this without glycemic control. So only the referral will happen. So I think these are the two challenges which both the fraternity may be facing. Because your priority is also because the patient has come with a different set of complaints. And if you start talking about diabetes and the glycemia and sending it to other person where they need to get their diabetes checked and treated, adding more cost to their more worries to their to them. So how to address this? So what are the ways which this esteemed panel can think of addressing all these issues?
Right. Spot on. In fact, not for just periodontal needs, Dr. Amit, I would say it's a general dentist also needs to be made aware. I mean, it's not about the periodontal disease only for the periodontist. General dentists, there are so many lacunae actually, and that is why we are meeting for this. And probably tomorrow, when we have the integrated healthcare panel discussion, I think there's a blast of questions that's going to be pouring in from each one of us. So let's just keep ourselves braced for tomorrow's panel discussion. And I'm sure the moderator is already logged in, so he will be just taking insight from today's and carrying it forward. Yes, Dr. Balaji.
I just have one observation and one question for Dr. Amit. I'm really very happy about the recommendations, and the outcomes are interrelated, which you said, and also spoke about screening the patients who are less than 45 years of age for seeing the diabetes if somebody from their family is suffering from diabetes. In one of the slides, you also spoke about sudden loss of weight. I just wanted to know when we are speaking about sudden loss of weight, what should be our criteria? How much weight loss in how much time should we consider for this to be for the bell to ring for us?
See, any weight which is lost unintentionally should be addressed. So there cannot be, for example, for cancers, malignancies, more than 10% weight loss is considered clinically much significant. So if somebody is losing weight without any intention and they end up losing 10% of their body weight, then something is definitely fishy and or alarming. We need to take care of that. Sometimes what happens is that this people with type 2 diabetes especially, they are overweight. So when they start losing 3 to 5 kg of weight, they don't realize that. They feel that, and most of the time credit is given to some of the preventive measures they are taking, right? So a 3 to 5 kg weight loss is very easily overlooked by obese person because it is happening in the right direction. And so it may not be a very serious concern for that person because without doing anything, you are losing weight. So we need to take from that point of view. So 10% is something which is very, very significant. But even if you are losing 5% without doing anything, then we need to think that what is happening.
So what was the time frame, Dr. Amit, would you say loss in how much time frame would you think is a ballpark to assess?
Maybe 3 to 6 months.
3 to 6 months, right. Because many times we have seen non-diabetic history or any other medical history, people lose their weight, probably aging is a process, sarcopenia starts happening, sort of a thing. Yeah, got it. Yeah. Any other questions from the faculties who are there?
Okay, there is a question on the YouTube.
Chat box. Yeah.
Yeah. I don't know whether it's a question. Okay, I'll just read it. As there is bidirectional relationship between dental health and diabetes, why we lack regular dental check at least once a year in all diabetics as we do for retinopathy and neuropathy, incorporated in diabetes management guidelines. So they are asking why are we lacking in the dental checkup for a diabetic patient when we are already checking for retinopathy and neuropathy. Sir, any input, sir?
I think, Dr. Balaji, this is what the problem is. And many of the times, the doctors, they do make recommendations. But let me tell you that there is a problem with the retinopathy screening also. So it is important to have the screening facility right at the point of care itself. For example, nowadays, if you suspect diabetes in a patient in your dental chamber, then immediately if you have access to a glucometer, you will immediately test the blood sugar and you will come to know that this patient is having diabetes, right? Similarly, physicians, they can screen, and if they find that the oral health is not good, and Dr. Sangeeta has already made a questionnaire with the help of this interest group, which I think we are going to circulate very soon, that what should be the minimum things a dentist should look for whenever a patient with diabetes is coming to them, and what should be the minimum things a physician should look for whenever a patient with diabetes is coming to them as far as the oral health is concerned. So I think it needs more and more education awareness, and maybe if we can have some telepathy kind of services where we are able to click the photograph and send it to the dental chamber that yes, this is
you have a point. In fact, we had discussed at one point some AI, if not an AI, a simple mobile camera picture, and quickly WhatsApp to your dental colleague, and something will be coming out from there. Put it like this.
Yes.
Easiest way of accessing.
So at least the patient knows that I have been seen, and there is a diagnosis that there is a problem with my teeth.
Exactly.
So you can always guide that patient that yes, you need say dental consultation.
Right.
So
probably Sangeeta, you can the diabetologist can have an intraoral camera and just put it and it reflects on the other side.
Intraoral mobile cameras are good enough. Click picture and send it across to a dentist.
No, I was more live, showing it live.
True.
Just to that point, because the AI we are using for the diabetic retinopathy,
they are
the photograph of the retina, and the AI tells us that there is a retinopathy or not. And even if the AI is not there, that image goes to the ophthalmologist. Within few minutes, or maybe after a specific time window, we will get the report that what is a report of the retina scan.
There is a very bleak documentation of AI in dental caries. Very bleak documentation. It's like 1 or 2 studies are there, not more than that. So probably it's a way to go. Probably sometime in future, something gets picked up. Any other question?
One question from Vandana ma'am.
Yeah.
Non-invasive blood sugar level gadget, is it available in market? Is it reliable? And any recommendations? Please update.
See, if you're talking about non-invasive blood glucose monitoring, then there are two set of things. One is a continuous glucose monitoring sensor, but it is not a non-invasive. There is a filament which is just placed subcutaneously. So the CGMs are quite reliable, and 2 types of CGMs are available in India. And Dominica is from the Europe, and I think there are more than 10 to 15 types of CGM devices which are available in the European countries. So there are many devices which are available as far as the continuous glucose monitoring systems are concerned. But they are slightly invasive in nature, but you just need to put a patch, and that patch will be having a small filament which is placed subcutaneously, and through the sensors, the sugar, the interstitial blood glucose levels, they are tested regularly. If you're talking about a non-invasive glucose meter like an Apple Watch or something like that, which can monitor blood sugar without totally non-invasive. So right now, there are no validated devices which are available. So right now, there is no device globally which is approved by FDA or by any, or is EU certified, which can test the blood glucose non-invasively. But in near future, there is a strong possibility that we may be having these devices, and many of the technology meetings all across the world many of the startups, many of the tech giants, they are working in this direction, and it may be a future soon.
Who knows, it might come out from India only.
Absolutely, absolutely.
Vandana ma'am, I hope your question is answered.
Yeah, I've been trying to look into a lot of these things because people are scared to check their blood sugar level because they have to poke their fingers every other time. But as you said, innovations start from India, and many of them are already there. And from this group, I think they should really concentrate on that so that will be very helpful to many of the diabetics in the India or the for the regular checkup. Even in the dental clinics, if we have this, it's good for us to diagnose also. Balaji, actually, we have identified a lot of diabetics through their breath halitosis, as my clinical experience goes. I have already had, we have informed them that they must be having some diabetic status because without their knowledge, they're not aware of it actually. But by the time they are tested, they have had their high blood sugar levels, and that has been a very good role played by the periodontists in the clinic. Especially two things. One is the halitosis, and the second one is the periodontitis status. Multiple abscesses. That's my experience, clinical experience. And way to go with periodontists. And as a subject, I would always say we have played quite an important role in diagnosing these conditions where the patients are not aware. And I hope such kind of clinical conditions, regular data being developed, which is a most, I would say, shortcoming in the literature from India, from the many of the institutions. It's just to say that we go ahead, that it is there, but it's never been studied. And if we can do that, that's the first thing that can go with this group, and then we can have very good evidence for a lot of things. All the periodontitis patients are diabetics, and all the diabetics are periodontitis is never answered. It's never answered because there are multiple factors.
Yes.
I would always say this group has to take up, and any of the institutions or the centers where they can develop all this, and then that is the most lacking part of this too. I would say very diseases which dampen one's interest in lives also sometimes, especially periodontitis, and diabetics as always. So I wish that goes around. And with this kind of innovation from this group, I think they could really concentrate on that to bring that here and then go ahead. So that would be very interesting, Dr. Amit. You spoke more of periodontitis as a diabetic specialty, and I enjoyed that, and thanks for that. And Balaji, hi. I always been yes. Thanks a lot.
Selva wants to say something, I suppose.
Selva wants to say something. Dr. Selva Kumar.
Dr. Balaji, thank you. Hello.
Yeah,
please go on. We can hear you.
Yeah. This question is for Dr. Amit, sir. There are a lot of drugs have been prescribed. Oral hypoglycemic agents have been prescribed. What is its effect on periodontal tissues, oral tissues? Does it sometimes the latest drug that has been prescribed is SGLT2 inhibitors. It causes excessive passage of glucose in the urine. It can have its effect on renal parameters on later stage. It can cause glycosuria. Same way, like drug-induced gingival enlargement, does the oral hypoglycemic agents, does it has any effect on the oral tissues? We are giving lot of drugs without seeing for the oral manifestation. Are we having any conditions like that? The oral hypoglycemic agents.
Dr. Selva Kumar, I think you have asked a very, very important question, and thank you for asking that. As far as the SGLT2 inhibitors are concerned, you have specifically asked for that class of drug. So SGLT2 inhibitors, they are a novel class of drug. Nowadays, they are used for the management of type 2 diabetes, and they work by inducing glycosuria. and they inhibit the SGLT2 receptors, but it has been shown in various studies and trials, they are actually cardio as well as renoprotective in nature. So they are being now used for the patients with the CKD to slow the progression of the CKD in patients with diabetes. And also this class of drug is being used in patients with heart failure also, even without diabetes, right? So this is the indication for SGLT2 inhibitors. As far as the oral tissue, there is no, I think, no specific side effects which has been mentioned in literature. There may be few very rare, maybe some drug reactions may be there, which may be seen in the oral cavity, but not as a prominent side effect or as a prominent adverse reaction with a drug that has been mentioned, which I am aware of, that I need to look for whenever we are prescribing these drugs.
Sir,
Okay,
second
Selva?
question.
Yeah, okay.
Second question, Dr. Balaji, can I ask?
Yeah, please go ahead.
Dr. Amit sir, previously it was told as dawn phenomena. The impaired glucose tolerance, the fasting blood glucose is higher. It is because of dawn phenomena. Then they said it is because of Someyagi phenomena. Is there any new concept in that, the rise in the blood sugar level at the early morning times? And as a dentist, if a patient comes to me for the extraction, to overcome this problem, what the diet restrictions or drugs we are supposed to prescribe? What should be done for those patients? Because after doing extraction, maybe they can develop hypoglycemia in the night and they can fall in the bathroom or they can feel sick in the bed itself. So what as a dentist we have to do in this case?
Yes. Dr. Selva Kumar, you have asked a very important question, and I would make it more simple. See, the patient only sees that there is a persistent hyperglycemia in the morning, right? Because they are not testing at the night. And now we want to understand whether the blood sugar are dipping at the night and after that they are rising, or whether the blood sugar they were not dipping at the night at all and it is persistently raised throughout the night. So if you can put these two phenomena in a very simple way like that. So if somebody is having hypoglycemia at the night, so what can happen is that the hypoglycemia can trigger all the defense mechanisms, which will ultimately lead to a release of stress hormones and the other hormones which are responsible for the reaction to the hypoglycemia. And these patients may have a very high blood glucose levels at the night time. So if you suspect hypoglycemia, especially somebody is on insulin, somebody is on a short-acting insulin at night, somebody is on sulfonylureas or the glenides, then these are the drugs where the risk of hypoglycemia is very much high. Then doing a 3 a.m. sugar or 4 a.m. sugar will help you in identifying that what kind of phenomena it is there. If patient sugar is going down at the 3 a.m. or right now in newer days, you can use a CGM where a continuous glucose monitoring system will tell you that what exactly is happening with the patient, whether it is a down phenomena or whether it is a down phenomena or whether it is a Somogoi effect. So it can be clearly demonstrated with the help of a CGM. So if a patient is on sulfonylurea, if a patient is on insulin, and the patient, you have documented that there is a hypoglycemia, then probably dose modification is required and some adjustment in the medication will also be required in these cases.
Thank you, sir.
Thank
So
you, Dr.
any specific instruction after a dental procedure in the evening time of the clinic should we have to give for the patient, for these patients?
I don't think there is any specific indication because if you are making your patient fast for too long, then the same set of rules apply which apply for any short-term surgery or any short duration surgery. Most of the time, dental procedures are of short duration in nature, and the intake of food is not inhibited for a very long duration. So I don't think most of the time there will be some adjustment required. But in case you are doing some major surgeries in the oral cavity, and then you need to follow the proper protocol as per the type of anesthesia you are using, as per the type of surgery you are planning, and how long will it take for the patient to be able to accept orally. So keeping all these things in mind, I think we can plan that how the patient should be treated.
Thank you, sir. Thank you so much.
Thank you.
Thank you,
Dr.
Sangeeta,
Selva.
Madam Balaji.
Thank you. I think Dr. Dominica is having some observation.
Yes, so I just want to make say a few words regarding the different kind of drugs. And so as long as I remember, there is some evidence that metformin could be associated with the deficiency of B12 vitamin. And then we as dentists can see this in form of either stomatitis of angular cholestasis as well. So probably these are the two symptoms we as a dentist we would be looking for if someone is taking metformin.
Yes, very rightly pointed out. But the only thing is that I was just thinking whether it is a direct effect of the metformin. So metformin itself directly doesn't causes any dental damage, but indirectly through the B12 deficiency, as rightly pointed by Dr. Dominica, can be. So we should be looking for any kind of
independently ruling out the vitamin B12 deficiency.
B12 deficiency, which is very, very common in our country.
Right.
Dr. Anandita has got an observation and a suggestion. She says, as periodontists, we need to highlight the fact that periodontal treatment helps reduce HbA1c levels. If diabetologists can put this fact across to their patients, the patients will become increasingly interested in seeking dental treatment.
Sangeeta ma'am.
Yes, please.
Just a metformin can cause tongue taste disturbance, no? That is one of the feature for our finding, for our oral manifestations.
Right.
Long-term use of
metformin,
there are a lot of.
But Dr. Selva Kumar, you are right. Metallic test can be there with some of the drugs, but only challenge is that that because of the diabetes itself, hyperglycemia itself, these patients may be having a lot of burning mouth syndrome, a lot of complications. So
taste toleration anyway will be there.
So it is very difficult to find out whether it is happening because of metformin or whether it is because of some other.
You cannot fish out one point. It's like multifaceted.
Right.
So, okay.
Right. Yes,
Any
Dr.
other questions?
Sangeeta.
Yeah, I think we are almost done for today's things. Yeah.
Yeah. Thank you.
Possibly we can wrap up the session and we bid goodbye for today and we reassemble tomorrow 8 p.m. sharp for the next day proceedings, and tomorrow's day is more of a clinical applications to be followed by the panel discussion.
I think Dr. Dominica wants to say something.
Yeah, Dr. Dominica.
Just last sentence. A piece of being, reassured. We use a lot of local anesthesia in dentistry, which often uses adrenaline as constrictor, and this usually higher our blood glucose. So I think for dentists, it's very reassuring that there's less likelihood of hypoglycemia during dental visit.
Right. Good observation. So should we sign out, Dr. Amit, for today?
Yes, Dr. Sangeeta, we can conclude today's session.
And so we just wrap up and thank you all.
It was great listening, Dr. Amit. Thank you very much. Dr. Sumita and Dr. Anupam also, thank you very much. Lovely being here.
Presentations were good, and tomorrow we again look forward for the next day. And for now, it's a good night for all. So have a safe night's sleep, and tomorrow we recollect again. Thank you so much.
Thank you.
Thank you, Dr. Sangeeta, Dr. Balaji.
Thank you, sir. Thank you, sir. Thank you very much.
Thank you.
Dominica, ma'am.
Yeah, thank you, Sangeeta.
Bye, Dominica. Bye.
Bye.